So good afternoon, everybody, and welcome to this webinar on an introduction session to managing addictions in psychiatric settings. My name is Julia Sinclair. I am the chair of the addictions faculty, and it really is my pleasure to welcome you to what I hope will be an enjoyable and informative hour for your CPD folder. The focus of this afternoon is very much for the generalist who's looking to improve their knowledge of these common co-occurring conditions. Clearly, we're constrained by time, but are in the process of developing a fuller training package. So please do give us your feedback on what you would like included, and do look out for those sessions when they are advertised. So what's the impetus behind this session? I believe that we've reached a crisis point about the place of addictions in psychiatry and the significant impact this is having on people and patients that we serve. Sorry, there's my declaration of interest. Back in 2012, in conjunction with the Academy of the Medical Royal Colleges, I was privileged to lead a project to gain consensus from all Royal Colleges about the core competencies for doctors working in any specialty. The intention then, as now, is to bring the management of co-occurring alcohol and other substance use disorders back into mainstream clinical practice, rather than separating them out as dual diagnosis. Pretty much every policy document of the last 10 years has encouraged a no wrong door approach, and I'm hopeful that the NHS mental health transformation plan, with the specific mention of integrating support for coexisting substance use, may finally embed this approach within our mental health services. The other challenge, as many of you are aware, is that recent cuts to specialist addiction service funding and the move from NHS to local authority commissioning have added to this sense of disconnection and resulted in a reduction of training opportunities for psychiatrists and joined up care for patients and their families. We are losing, or have lost, in several regions already, higher training posts in addictions. This was the feedback from heads of schools just before COVID about the filled posts across the regions. The impact of this is a drop from over 70 training posts available annually to around 20, and has resulted in significant lost opportunities for adult psychiatrists to gain an endorsement in addiction and consequent loss of expertise in the treatment system. However, you're not here for an hour of doom, but hopefully to be part of the solution to improving our offer of patient-centred care. So to close this introduction, I'd like to highlight two positive things. The first is that the GMC have formally changed their use of terminology for doctors referred to them on health grounds. I received this email from them yesterday, using the diagnostic terms of alcohol use disorder and substance use disorder rather than misuse or abuse. This is part of their work to reduce the stigma towards doctors with medical undertakings due to alcohol and other substance use disorders, treating it as a clinical problem rather than as a criminal justice one. And I hope it is one that we can extend to our patients in mental health services too. Second is, within the addictions faculty, we've set up a training task force led initially by Louise Sell and now by Sarah Welch, who's co-chairing this afternoon with me. You can see the link here to the full report in this slide, but just to highlight the main actions. We've successfully included in the new curriculum, core curriculum, the requirement that all core trainees undertake 2 workplace-based assessments in patients with either a co-occurring or a primary substance use disorder or other addiction. We're developing an addiction tutor network to support this. So if you're interested in being part of this exciting new peer network, please do be in touch. And we're working with a range of national and regional stakeholders to reinstate lost higher training posts in addictions. So on to our bite-sized talks, and then lots of time, I hope, for discussion. We'll all introduce ourselves. Please do post questions in the chat. And my colleague Sarah Welch, who's with me today, will use these to curate the beginning of our Q&A session, and we will take it from there. So moving on to the first, to managing alcohol withdrawal in psychiatric settings. The scale of alcohol use, this is in England, is clear to see here. And for the purposes of this talk, I'll be focusing on this smaller group, but it's still 1% of the population and potentially up to 8 to 10% of people presenting to mental health services who may be in need of alcohol withdrawal. In terms of COVID, within the UK, our prevalence of excessive drinking monitored by the Audit C has gone up significantly. This is the National Alcohol Toolkit Survey. And as you can see, this was during lockdown of last March. And having seen this picture recently going about social media, it's pretty clear that actually our relationship with alcohol is not going to get healthier anytime soon. So that has a number of implications. The first, and really seriously, is that actually our rates of alcohol-specific deaths are also at their highest of all time since monitoring began back in 2001. And again, there was a peak in those deaths in rates in quarters 2 and 3 of last year, which were significantly higher than at any other year back to 2001. In terms of positive things, there is an alcohol clinical guideline, which will be published or out for consultation and then published in summer of this year. We're in its final stages of drafting that, and it will be the equivalent to the Orange Book for substance use disorders that will be familiar to many of you, and hopefully a really useful guide of to consult in terms of managing patients. So what I want to do for the main part of this talk is think about the general principles for managing alcohol dependence and specifically assisted withdrawal in psychiatric sessions. But I need to think about that really within the sandwich of, first of all, screening, so that we can identify people who may have need of medically assisted withdrawal, and then relapse prevention, remembering that, of course, medically assisted withdrawal or detox is not the end of treatment, but the beginning. So my aim would be that really we screen for alcohol use as integral to every single clinical history. It's what we teach our medical students now and our junior doctors, to be able to quantify that in terms of volume, percentage and frequency. And use of a structured clinical tool such as the Alcohol Use Disorders Identification Test, or audit. And what you can see here are the first 3 consumption questions of the audit. So you'd ask a patient, or rather you get them to answer, how often do you have a drink containing alcohol? And as you can see, you score that 0 to 4. How many units of alcohol do you drink on a typical day when you're drinking? So that behoves us to know our units of alcohol. And then how often have you had 6 or more units if you're a woman, or 8 or more if you're a man, on a single occasion in the last year? And the advantage of the Audit C over something like the CAGE is it gives you a really objective sense of how much people are drinking. It's quite therapeutic in terms of being able to help and guide feedback that you may give, and it doesn't wind anybody up. The CAGE questionnaires in themselves can be quite counter-therapeutic. So for people scoring 5 or more, probably in a mental health setting, you'd probably want to then explore their drinking patterns slightly more with use of the structured tools such as the full audit. And if they were at risk of alcohol withdrawal, there are other tools such as the SADQ, the Severity of Alcohol Dependence Questionnaire, and the Clinical Institute Withdrawal from Alcohol, which is a rating scale for the severity of actual alcohol withdrawal symptoms. So if you're seeing a patient, when would you consider medically assisted withdrawal? Well, I think, as I've said, you take a history, and my sort of rule of thumb would be anybody who's daily or near daily drinking of 10 or more units, which may be less in the elderly, should at least be considered in that at-risk pool. Anyone who's had a previous history of withdrawal symptoms or severe complications from alcohol withdrawal should flag up some red alerts. And people who are already presenting with agitation, craving, or just irritability. And I think this is often the thing with patients with co-occurring alcohol use, is people often think they're difficult patients, but often they present in alcohol withdrawal and they're irritable, like people in pain. They need to have that settled before you can have a proper assessment with them. Anyone who scored more than 10 on the CWAR really is going to be in need of some form of medical assisted withdrawal. And so as part of the assessment for that, you need to do a physical examination to look at signs of agitation, such as tachycardia, high blood pressure, any sort of related physical comorbidities such as confusion and liver disease, which will then need to be followed up with the relevant blood tests and, if you can, a breath alcohol level. And breath alcohol is really important, I think, in patients who've also got a high CWAR. Sometimes I think people think if there's alcohol in the body, you shouldn't start a detox, but this is a real misunderstanding. If you've got alcohol in the body and somebody's in withdrawal, it's just a flag that they're likely to go into quite significant withdrawal because they're already demonstrating symptoms despite having alcohol in the body. We also encourage people to maintain a really high index of suspicion for Wernicke-Korsakoff syndrome and other alcohol-related brain damage, simply because the vast majority of people will just present with confusion rather than this classical triad that we all did for our membership of confusion, ataxia, and ophthalmoplegia. So I think you need to do a good baseline assessment, and then really the aim of a medically assisted withdrawal is both to manage symptoms, but also to prevent complications such as seizures, delirium tremens, and Wernicke-Korsakoff syndrome. Now this slide I've taken from the Australian guidelines for the management of alcohol withdrawal, because I just think it's really helpful. It divides the signs and symptoms that you might see into these three categories: autonomic hyperactivity, which we might be quite familiar with, but to remember, please, at the severe level, that also includes dehydration and electrolyte imbalances, which can significantly worsen prognosis and also complicate the management. So it's important to have tested for those. You've then got the gastrointestinal features and then the cognitive and perceptual changes. That might be something as simple as poor concentration and anxiety, and then it sort of starts to ramp up through psychomotor agitation, disturbed sleep, seizures, hallucinations, and what may appear to be frank psychosis. And on the right here, what you can see is the timeline in which these present. And I think this is also helpful to remember. The first 24 to 48 hours, people may have seizures. And then for the majority of people, mainly those who haven't had seizures, they may then have quite a mild course if it's adequately treated, with degrees of anxiety, agitation, and tremor kept under control by some benzodiazepines. The worry is by kind of 72 hours, if that isn't settling and things seem to be getting worse rather than better, I'd really encourage you to think of that as a red flag that you might be heading into severe alcohol withdrawal and potentially DTs, which, as we know, is a medical emergency and really requires some pretty robust treatment. But taking a step back again in terms of the principles of treatment, which is all we've got time to go through at this point, but can discuss more in the questions. In terms of mental health settings, it might seem silly, but follow your trust policy. There will be one. Check it's up to date, and particularly when the guidelines come out in July, it's a really good opportunity to review those guidelines based on best practice. For most mental health trusts, that will recommend a fixed reducing regime of either chlordiazepoxide or benzodiazepine. And by a fixed reducing regime, I mean something which is like 20 milligrams of, say, chlordiazepoxide 4 times a day, reduced over 5 to 7 days, with different levels of regime dependent on the severity of alcohol withdrawal. For people in need of withdrawal, they should have parenteral thiamine and Pabrinex, and so this should be given IM or IV depending on your setting and what is available for you. And then really the aim, I think, of a good management of alcohol withdrawal is to walk that pathway between monitoring for good symptom control and ensuring the patient isn't at risk of going into respiratory depression. And I think the key point, if you remember anything from this talk, it's benzodiazepines as first, second, and third line. And in the hospital where I worked at the moment, we've had quite a few cases where people have been moved onto antipsychotics a bit too early, and actually their course has been far worse. You may need really high doses of benzodiazepines, and sometimes I think people, they get worried. They've already given what seems like a high dose, 200 milligrams of chlordiazepoxide. It hasn't really had an effect. And so what I'd encourage you to do at that point is carry on giving it, so long as there's no signs of respiratory depression, and be aware of active metabolites. So really only neuroleptics should be used as symptomatic management if high dose benzodiazepines are not managing those psychotic symptoms. And a review by Mayo Smith back in 2004 kind of showed really, I think, quite clearly that neuroleptics are less effective and significantly increase the relative risk of death by over 6 compared to sedatives. So I think, that's the other main take-home point, please, is try to avoid the use of neuroleptics unless that's significantly underpinned by already high doses of benzodiazepines. And then if the relapse, the detox has gone well, remember that is only the start of treatment, not the end, and please think relapse prevention. And in terms of relapse prevention, there are obviously pharmacological treatments underpinned by a psychosocial framework. And this table comes from a summary that we did for advances in psychiatric treatment. So again, for those of you who are wanting to know more, please do look at that. And as you can see, the main drugs that we use for relapse prevention, which are licensed, are acamprosate, naltrexone, disulfiram, and nalmefene. Baclofen is not licensed in the UK, but it is licensed in France, and it is used quite significantly. However, of all of the drugs that you might wish to use for relapse prevention, and as I said, this is just very much an overview of this, baclofen is the one that I would probably use it with greatest caution in the mental health population, partly because of the substantial risk of sedation in overdose, and also that it may precipitate mania in patients with affective disorders. So I'd use it very cautiously, whereas acamprosate and naltrexone are both, I think, pretty safe and relatively easy to use. For both naltrexone and nalmefene, they're opioid antagonists, so you really do need to be aware of the fact of what your patients might be taking and whether they're taking any opioid, codeine-containing compounds. Disulfiram, interestingly, there's a reasonable evidence base for its use in the comorbid condition. I mean, they're not randomized controlled trials, but they are good prospective and retrospective studies. And certainly the fear that there used to be that it would precipitate psychosis has not been borne out in recent evidence using modern doses of 200 milligrams a day, as opposed to 2 grams, which were the doses used in the 50 from which that original evidence base came. And so just finally to think about psychosocial treatment with the co-occurring psychiatric conditions, there's been a couple of reviews. Cochrane most recently found that no intervention was superior for either treatment retention or substance use or mental health outcomes. That does not mean that it wasn't effective. What it means is that there was none that was shown to be superior to any other. And I think what's a helpful summary of an older review now, which essentially kind of says, if it's effective as a psychosocial intervention in psychiatric treatment, it will also work for those with comorbidity, and those psychosocial treatments that are effective in reducing substance use are also likely to work in those who in addition have a comorbid psychiatric illness. So I think the encouragement would be to try it and to try and manage it within as part of an integrated package of care. And so just finally, at the end of this first part, these would be my calls really, and our implications to practice. I would say that as psychiatrists, we really need to reclaim alcohol use disorder primarily as a disease of the mind, and embrace the principles of no wrong door so that we can really offer our patients person-centered care. In terms of the general principles of managing alcohol withdrawal, I think it's got to start with asking everyone about their alcohol use and being able to, systematically have an objective idea of how much people are using. And in terms of medically assisted withdrawal, to manage symptoms and prevent complications, you need a good baseline assessment of severity and potential risks, ongoing regular structured monitoring. High dose benzodiazepines may be required, and you need to just make sure that your patients aren't at risk of going into respiratory depression, but always, always please think relapse prevention. That is both psychosocial and pharmacological, and could be easily integrated into our treatment of patients more broadly in terms of their mental disorder. So that's the first part of this talk, and it's now my pleasure to hand over to my colleague, Dr. Lesley Peters, who is in Manchester and is going to talk to us about managing opioid dependence in psychiatric settings. Over to you, Lesley.
Okay, that's fine. Yeah. Okay. Yeah. So, I really apologise. Some general principles about this. So, people dependent on opioids, one of the things they're concerned about is being admitted to hospital and not receiving adequate medication to deal with withdrawal symptoms. So, what they do need is reassurance They need assessment and suitable prescribing as soon as safely possible after admission. And I think the key there is safely possible. So it has to be remembered that opioid withdrawal symptoms, unlike alcohol withdrawal, are not generally life-threatening, but they can be associated with such significant anxiety and distress that that can really affect engagement with the treatment of comorbid mental, physical and health problems. So people may leave the ward and just not engage in the treatment. So it's key as well for early liaison with drug treatment services for advice and support, both on admission and on discharge. I think there should always be naloxone in the emergency box on mental health wards, even if people are not known to be on opioid substitution medication. And opioid substitution medication normally prescribed is usually oral methadone or buprenorphine. So for community patients, the community drug service will normally be prescribing for your patients. And ensuring good supervision, good management of opioid dependence, optimal treatment is key to managing, getting the best for psychiatric outcomes. Next slide, please. So just some important facts about methadone. So it's normally prescribed as methadone oral solution, 1 milligram and 1 ml, and that will be the formulation that people in the community will be on. It's important to know that with repeated dosing, the half-life is around 24 hours. So it's a once-a-day medication. It takes around 4 hours after a dose to reach peak effects. And that's important because people may complain that they're not feeling any effect, 20 minutes, half an hour after a dose, but you need to wait to be able to establish the true effect of any given dose. It's metabolized by the liver. So again, you have to be cautious in those with hepatic impairment. And then it takes about 5 days, around about 5 half-lives after a last dose increase to reach a steady state. So there's a significant risk of cumulative toxicity. And this is one of the key issues with methadone, when people are being started on methadone because of the build-up. So you need to start and not increase too quickly to avoid this. In the community, the optimal dose will be 60 to 120 milligrams daily after titration, but you wouldn't be expected to reach those sort of levels during an inpatient admission usually. And another thing important for psychiatry is that methadone itself is associated with QTc prolongation. So we should need to undertake ECGs, particularly on people on certain antipsychotics and antidepressants. So again, it's important that there's good linking between community psychiatric teams and the community drug services. Next slide, please. So again, the alternative for opioid substitution treatment is usually buprenorphine. Now, most people will probably be on methadone, but up to a quarter of people on some drug services are prescribed buprenorphine. So this is a sublingual tablet, or it's now also available as what's called an oral lyophilizate or wafer, which dissolves on top of the tongue. But most patients will refer to this as Esprinor. As opposed to methadone, this is a partial agonist. So that means that it has a milder effect than methadone itself, milder opioid effect, and makes it safer in overdose. So for certain psychiatric patients, the community drug service may prefer buprenorphine, particularly to reduce the risks of deliberate self-harm. One of the key issues, however, is that buprenorphine will displace heroin or methadone from opioid receptors, so that can precipitate a withdrawal syndrome. So it's really important not to start buprenorphine until around 12 hours after you've last used heroin, or at least 24 hours after you've last used methadone. So for these reasons, it's less likely that you'll be initiating buprenorphine in an acute admission because it's harder to titrate onto a stabilized dose. In the community, you may find that your patients will be on 12 to 16 milligrams daily. Next slide, please. Right. So in terms of assessment of opioid dependence, again, it's back to first principles, and it starts with taking a good drug using history. So you want to find out the use of opiates, and then the frequency of use. So for someone who's dependent, that will usually mean daily use of the opioid. You want to know the amount and the route of use, for instance, whether they're injecting or smoking, because that also indicates what physical harms they may be experiencing. You also want to take a history around their other drug use and alcohol use, because it's important to remember that polydrug use these days is the norm. You'll want to look at withdrawal symptoms, which we'll come on to in a minute, and then also physical examination, particularly directed around confirming heroin or opioid use, for instance, injection sites. Ideally, there should be drug screening, but I'm aware that not every inpatient unit perhaps has access to point of care drugs tests. So that's something to consider for your inpatient unit. And also key in establishing opioid dependence diagnosis is third-party information, particularly if someone's on a substitute medication. And that can be obtained from the drug service, or the community pharmacist is a really, really good source of information, particularly out of hours, because they are often seeing the patient 6 or 7 days per week to dispense the methadone or buprenorphine. Next slide, please. So in terms of opioid withdrawal, there's a classical withdrawal syndrome, as there's a classical alcohol withdrawal syndrome, and this shows that the symptoms increase in severity with time since people last used opioids. So milder symptoms at the start, such as craving and anxiety, can often be quite subjective in nature, proceeding through more objective signs such as yawning, sweating, a runny nose, and at the more severe end, ending up with vomiting and diarrhea. In the community, you rarely see people presenting in quite significant withdrawal because people will obviously source medication to relieve their symptoms. Next slide, please. So in terms of withdrawal from heroin, onset is around 6 hours to 8 hours after the last dose. So if someone's admitted, say, in an evening to a ward, you can expect that by the morning they may be experiencing signs of opioid withdrawal. It peaks around 2 to 3 days. For methadone, which is a long-acting opioid, you're looking about a day to 2 days before they experiencing withdrawal symptoms, and again they peak around 6 days. Next slide, please. So this is the opioid equivalent of the CWA, the Clinical Opiate Withdrawal Scale, or COWS. Now, general hospitals may use this to determine when to give opioid replacement according to the rating scales. For instance, some protocols will not offer opioid substitute therapy unless the withdrawal rating is over 12, indicating moderate withdrawal. So it covers a lot of the opioid withdrawal symptoms that we mentioned. It's not universally used in hospitals, and certainly it's not as well used as the CWA is for alcohol, but it does enable staff to make sure that they are checking all the requisite withdrawal symptoms. Next slide, please. Yes, so back to drug screening. Urine drug screening with point of care near patient testing is the easiest testing. It's important to know that heroin will show as an opiate positive. There's no specific near patient testing that would determine if it's heroin as opposed to something like codeine. So morphine tablets, codeine tablets, dihydrocodeine will all show as opiate positive as well. But methadone and buprenorphine have specific tests, so won't show opiate positive, but will show, if you've got the correct test, whether someone's taking their methadone or their buprenorphine. So it's really important to interpret a drug screen in the context of the history and the presentation, because someone could be opiate positive using 8 codeine a day or 4 bags of heroin a day, and obviously the following treatment would be very different. Next slide, please. So if we look first at those who are prescribed opioid substitution treatment in the community, and someone says admitted to the ward with an acute psychiatric presentation, the first port of call would be to liaise with the community drug service and the pharmacist to confirm that current prescription. It's also very important to cancel the community prescription, because it's not unheard of that people will either leave the ward to collect the prescription or will get a friend or relative to collect the prescription on their behalf. So what you want to establish is the daily dose of substitute prescribed. You want to look at the dispensing arrangements and whether they are supervised. And that is key, because if the dispensing arrangements, if it's not supervised, you cannot be certain that the person is taking that methadone or taking the whole dose. So you have to check out the recent compliance. And unless someone has been compliant with a supervised dose, as I said, you can't assume tolerance to that dose. So only if you can confirm compliance will you be able to give the dose. So it would mean that dose could usually be prescribed on the ward, but again, that would be subject to their acute presentation. So for instance, if someone was presenting drowsy or with an acute head injury, you would seek further advice before issuing the dose. And for methadone, you can also give this as once a day, or for additional assurance, you could give it in 2 divided doses. Next slide, please. Yeah, so this is slides really just some pointers for those who are not receiving opioid substitution therapy in the community, or who are not supervised, or where you cannot confirm their medication. So for instance, someone admitted on a Sunday. So here you have to be very cautious. So if restarting or starting methadone, you need to titrate that dose carefully. And as Julia said, with alcohol, it's a balance against titrating against withdrawal symptoms and also monitoring for intoxication. So your hospital should have protocols about managing illicit drug use. So again, it's a case of following those protocols. And a great source of information is the hospital pharmacist. So again, you would be aiming for the careful dosing around 10 mils 4 to 6 hourly, and you would not be expecting to prescribe more than 40 milligrams in the first 24 hours. So, but if restarting or starting buprenorphine, again, you have to remember to manage that starting dose with the interval after the last use heroin to avoid precipitating withdrawal. As I say, most people will be finding they'll be starting methadone on the ward rather than buprenorphine. Again, do not give the medication if they're drowsy or intoxicated. And you have to be very careful in prescribing additional drugs such as benzodiazepines because of the additive respiratory depressant effect, particularly if during the titration period. And then again, key, I can't emphasize enough really, is early liaison with community services, because some of the most difficult decisions are for those patients who are not on supervised dispensing. And since we've had the COVID pandemic, the rates of supervision have greatly reduced. So a lot more patients are now in receipt of take-home medication, often up to 7 days at a time. And it can be very difficult when someone's admitted to a ward who's on, say, 70 mils of methadone on a weekly pickup, and you're having to manage that without knowing their true compliance. But the drug service usually have very good knowledge about the individual patients, and then maybe to advise, once you've started the initial titration, maybe to able to advise about a either quicker or safer titration based on their knowledge of that individual. And then just a point of caution is, so a lot of people will have doses in possession. So if someone picks up weekly on a Monday and is admitted to hospital on a Tuesday, they may actually have 6 days worth of medication in their possession. So it's important to know what they've been doing with that medication before you initiate prescribing. Next slide, please. And this is the my last slide. This is the Orange Guidelines that Julia was talking about, which summarises the guidance in the UK on drug misuse and dependence. And it's for both generalists and specialists. And it's got various sections, including one on treatment within the hospital setting. And I think it's a really good resource to flag up to your ward staff, just even to dip in and out of as required. Next slide, please. Right, thank you. That's the end of my talk. And the next slide is just for Nikki, who's going to talk to us now about methamphetamine intoxication and psychosis. Thank you.
Okay, hi everybody. My name's Nicola Kalk, and I am a consultant addiction psychiatrist working in a general hospital as part of an alcohol care team. I apologise, I'm trying to start my slideshow and it's not letting me. And I'm going to try and talk slowly and cover the emergency management of someone who has taken methamphetamine and is presenting with psychotic symptoms. And I suppose there's a liaison-y slant to this. You would see it in the Section 136 suite or in A&E. Now, methamphetamine is a stimulant. It's a type of amphetamine. And in the UK, it's used by a very small proportion of the population, so less than 1% of the population. Overwhelmingly in the UK, in the population of men who have sex with men, often in the context of chemsex. So they don't use methamphetamine alone. It's often in combination with methadone, which is a novel psychoactive stimulant, and GBL, a sedative. Now, given that use is particularly rare, there's a disproportionate burden on emergency services. So around 5% of our alcohol care team caseload take methamphetamine as their primary substance use. They're 90% men, and they have a median age of 38. The other important thing to point out in the UK is that it's very common for methamphetamine to be injected. So it's about half injected or smoked. And that has risk implications for bloodborne viruses. Now, why should methamphetamine use be associated with psychosis? Well, I mean, it is a dopaminergic drug. It reduces the uptake of dopamine from the synapse, as well as stimulating synaptic release of dopamine into the synapse. So it's not surprising, given what we know about hyperactivity in the mesolimbic tract and sort of primary psychosis, that methamphetamine use should predispose. And in fact, if you take a sort of general population survey in an area where they use lots of methamphetamine, so in Australia, a survey of 300 methamphetamine users just recruited via newspaper advertisements, 13% reported psychotic symptoms. And in fact, if you included sort of subsyndromic unusual thoughts or experiences or vague suspiciousness, it was up to 23%. If they were methamphetamine dependent, so if they met sort of ICD-10 criteria for dependence, so loss of control, craving, continued use despite evidence of harm tolerance, etc., then the odds ratio of having those psychotic symptoms went up to about 3 times versus sort of sporadic use. And there's a very strong relationship to when people are using meth. I think this really almost gets in the way of care, this relationship. So Rebecca McKetton, who's one of the really preeminent researchers on methamphetamine and the complications, examined people's psychotic experiences during a month where they're not using methamphetamine relative to a month where they are using methamphetamine. And she found that if you're using sporadically, so less than 15 days a month, then your odds ratio of experiencing psychotic symptoms was 4 relative to a month where you're not using. If you're using just about every day, then the odds ratio is about 11. And use of cannabis and alcohol alongside your methamphetamine increase that risk even further. Phenomenologically, what we see and what the literature reflects is that, and what patients describe, is that the psychotic phenomena start earlier in each binge. They last longer during each binge. In most cases, they resolve within a couple of weeks, but actually McKetton again did some longitudinal work and found that 30% of patients reported ongoing psychotic symptoms longer than 1 month following their last methamphetamine consumption. I think I need to make a really important point. And this addresses the stigma that these patients face throughout the world. They find it very difficult to get accepted into mainstream psychiatric services because they take drugs. What I want to point out is that, again, Rebecca McKetton looked at patients' notes. So she looked at people 6 years down the line and tried to distinguish those who ended up actually with a diagnosis of schizophrenia or a similar diagnosis, and those who continued to have a methamphetamine-related psychosis diagnosis. And what she found was actually, looking at their first presentation, you couldn't actually tell the difference. So this is a very rich slide, and I don't want you to read through it. All I want to point out to you is that the only significant difference was in the presence of running commentary hallucinations. And those were only present in 20% of the people who turned out to have schizophrenia later. So you can't distinguish. You can't say for sure when you meet this person in A&E, is this intoxication? Is this ongoing methamphetamine-related psychosis, or is this an organic, a first episode psychosis? And oftentimes liaison psychiatry teams can be reluctant to get involved with patients who've taken methamphetamine. But I would argue that if they're displaying psychotic symptoms, they have psychiatric needs and they need early liaison psychiatry involvement. So rapid tranquilization and behavioral containment are different in this group and require expertise to manage. If they're displaying psychotic symptoms, then a baseline assessment is important, because you're going to need to repeat assess and because they're potentially going to require onward psychiatric care. They may need quite a specialist capacity assessment. unless people are really in the acute phase of intoxication and quite agitated and aggressive, they can be sitting there in a very quietly paranoid state, being tremendously polite to the A&E SPR, but terrified. And it might not be something that's picked up by more generalist members of staff. So I would advocate that you get involved early. However, when you go and see them, now I'm not doing this in a systematic way, in that I'm not going to labour the point around taking a thorough history and all that kind of thing. I think that's been said before. But my thought process when I go and see someone with methamphetamine who's behaving oddly in A&E is the first thing I want to know is, when did they last take it? And are there any signs of intoxication? Because that's going to change my management. So you want to know when they last take it. And usually, even if someone's really quite in quite an altered state, they usually can report this. Or indeed, you can gain collateral around this because they're often there with a worried family member. They might be tachycardic, they might be hypertensive, they'll have dilated pupils, they'll be sweating, they'll be agitated, and there might be signs of increased muscle tension. They might have increased tone, clenching the jaw, grinding the jaw. In severe intoxication, muscle spasms. I recommend everybody gets a drip because they're dehydrated. They're all dehydrated. And that might be driving at least some of the tachycardia. And they need a proper neurological examination, if that's feasible, by the A&E SHO to exclude strokes, because this is one of the things we worry about with severe methamphetamine intoxication. They need an ECG if that's possible, or cardiac monitor if they're running particularly fast. And they need bloods. The most common reason that my patients get admitted to hospital is that they've been up for 3 days, engaging lots of physical activity, not really drinking, and with this increased muscle tone, and they get rhabdomyolysis. So you need to do a CK and you need to do Usnes because they might be in pre-renal failure or acute tubular necrosis secondary to the rhabdomyolysis. Then once you've established, so then you decide, is this acute intoxication phase, or can I safely say that's past? And you make a decision. The other differential you need to bear in mind in the UK is, are they G dependent? So this is a picture on the screen of G, which is an industrial solvent, which is taken as a sedative and aphrodisiac in combination with methamphetamine. It's highly dependence producing. If people are using it more than 5 days a week for 2 weeks, if they're using more than 15 mils a day, if they're waking up at night to use, if they report withdrawal symptoms, if they switch between alcohol or benzos and G when they can't get hold of G, then they have a high index of suspicion of them being G dependent. And that the complicating factor is that methamphetamine intoxication and G withdrawal can look really similar. They both share sweating, they both share agitation, they both share hypertension and tachycardia. And they both come on very quickly after your last use. The implication is that G withdrawal treatment is really, really different in that they need stratospheric doses of benzodiazepines, and many may need ITU. So you need to establish, could this be G withdrawal? Because if it could be G withdrawal, the regime that you're going to prescribe for benzodiazepines is going to be a great deal more aggressive. Okay, but say you've excluded that and you think, well, the likelihood is they're probably intoxicated and we need to see how they go. Our usual opening gambit is to give them a bit of diazepam 6 hourly as needed. So for agitation, not particularly for a withdrawal scale or anything like that. If they need parenteral, we go with lorazepam, and we try and get them to have some sleep, because oftentimes that really sorts things out. We use the Mental Capacity Act in this case and make sure that they're in a safe place. I want to point out really important differences in rapid tranq. One of the implications of the fact that this is a dopaminergic drug is they become really, really sensitive to EPSE's, particularly acute dystonic reactions. And I've seen really bad things in response to haloperidol used in rapid tranq for this group of patients. So in King's, we advocate aripiprazole rather than haloperidol because of its greater tolerability in the acute setting. Okay, then they go and they have a sleep. And you come and reassess them the next day. And I believe they need a psychiatric reassessment the next day. Now that's where you get into a complex decision-making process, because it may be that now they're medically fit. So say they don't have acute tubular necrosis and now they're medically fit. Now you're getting to the boundary of resolving acute intoxication. And when we say, well, that this is resolving intoxication, and when we say, oh, actually, this is drug-related psychosis because it's persisting beyond acute intoxication. And really, the boundary of that has not been studied. So personally, I take a pragmatic approach. When we need to make a decision, is there a role for a CDU? And what is the balance of physical and psychiatric needs? At the point where they're medically fit, an acute medical ward really isn't a good place for someone who's paranoid to be. And can be risky. So then we need to think about what is the role of psychiatric follow-up, and I would advocate that, and what is the role for continued antipsychotic prescribing. And I would say the two go together. Either you have someone who remembers the weird experience they have, but can acknowledge that it was related to the drug and they are back to normal, or you have someone with lingering paranoia, or in fact you take a history and you find that while this person's paranoia has been exacerbated by the methamphetamine, actually they're paranoid most of the time now. So you need to sort out the need for psychiatric follow-up and for review of the antipsychotic prescribing, because the evidence for continued maintenance prescribing of antipsychotics in this setting is really not clear. You also need to refer them to the local community drug and alcohol team, preferably one that is LGBTQ friendly, and pay attention to their sexual health. Just to flag up for reference that the evidence base for antipsychotic prescribing for methamphetamine-related psychosis is very small. It's small studies, they are very short. There's only one placebo-controlled double-blinded study I could find, which suggests that aripiprazole brought down the symptoms more quickly than placebo. Most of the other ones compare haloperidol to a second-generation antipsychotic. I want to draw your attention to Wang's paper, and the reason why Wang's paper is important is that they looked at tolerability in detail, and they found that both risperidone at a reasonably standard dose and aripiprazole at a reasonably standard dose were really poorly tolerated. So aripiprazole caused severe enough akathisia in a majority of patients to actually affect dropout. And there were high rates of dystonia. And these, although there was no significant difference, was sort of 80% in the risperidone group and around 60% in the aripiprazole group. So these guys are really, really sensitive to EPSEs. So there's no evidence on long-term prescribing. There's no evidence on depots. And that is why these guys need an appropriate period of follow-up care after they go home from A&E. And that's me. Now we're going to have a live Q&A chaired by Dr. Sarah Welsh. Thank you for your attention.
Hello. This is a rather challenging role here because we have absolutely loads of questions. What I would say is, looking at them, is there are a lot about alcohol, and that really highlights for us the need for the alcohol guidelines, which are coming out in the summer. So that's, very reassuring, because we will have these, because we're not going to be able to answer all of them. What I think I might do, though, is start with a couple of questions that are quite similar to one another about alcohol, and it relates to benzodiazepine regimes, whether one chooses a sort of score-driven, symptom-triggered alcohol detox regime or a fixed dose regime, which is actually very topical. And two people have asked that question, one of whom has used it because it's a trust policy and found it quite difficult. So I wondered if well, Julia and possibly Nikki want to comment on that.
So yeah, we're smiling because we were discussing this at the alcohol guidelines meeting just Tuesday. And, so I think a lot depends on the situation, the people you have around who are there to monitor things as much as the patients that you've got, if you see what I mean. So I think, as always with these things, it's the risk-benefit ratio. And for us in my general hospital and in many psychiatric wards, if you've got staff that are not necessarily really monitoring people very, sort of religiously and frequently, and there was another question about timing, so I'd say sort of hourly in the first instance, then you're going to miss symptoms that are going to kind of trigger you giving people the correct amount of benzodiazepine. And then the first symptom that will trigger anything happening is when they have a seizure. And that's one of the things we absolutely want to avoid. Whereas there are other places where, actually, particularly specialist units and some acute hospitals, where things are, the training of staff is so embedded that this is regular monitoring that you do, that it's actually part of their normal practice and no one would think about not monitoring. And therefore actually symptom triggers is as helpful. And I think the evidence has gone one way and then the other, depending on which, but the first NICE guideline, we felt that it probably was, the physicians felt that should probably be symptom triggered. As psychiatrists, we felt that actually it should be fixed dose. So really the answer to that is, it's not just about you and what you're prescribing and your patient, it's about the system that you're in. And that is really the main thing to consider.
Great. I think we'll move on. There is a very specific question which I think has a clear answer as well. So we might do that next in relation to alcohol withdrawal, and that concerns the use of anticonvulsants other than benzodiazepines as a sort of prophylaxis when you are prescribing for an alcohol withdrawal regime. The questioner asked specifically about valproate, but I think if we answer it more generally about anticonvulsant medication.
Nikki had her hand up. She was keen to answer, so go for it, Nikki.
I've just supervised a master's student where we did we updated the Cochrane systematic review of anti-epileptic drugs for alcohol withdrawal. The answer is no. They don't work as well as benzos. We don't agree with Martinotti's view of carbamazepine. So carbamazepine was the one thing that came up in the Martinotti review. They used stratospheric doses and they were poorly tolerated. So I don't think you can justify that. The only novel anti-epileptic that I think is worth considering further research in rather than using is lamotrigine in combination with benzodiazepines in the prevention of alcohol withdrawal seizures. But there's really no evidence to suggest that we should be using anti-epileptic drugs. And shout out to A&E doctors, please don't load people who come in with alcohol withdrawal seizures on Keppra, because there's no evidence to suggest it works.
And also obviously to remember that valproate should not be used in women of childbearing potential. So that also wipes out 50% of the population. So, I think it's the same principle as antipsychotics and benzos. This is a disorder that requires high doses of benzodiazepines to treat it. So if we treat them with high dose benzodiazepines, we won't need the antipsychotics, hopefully, or the antiepileptics.
And valproate is hepatotoxic. I mean, so lots of reasons not to use it.
If we take one more question about alcohol, because we've got very little time, that probably there's a question which is a little bit different, which is about the evidence base for acamprosate and naltrexone, which I know we've been talking mainly about a hospital setting, but it is important, as Julia said, to start thinking about relapse prevention right from the beginning. So
Absolutely. I'm happy to do that, because we reviewed this for NICE back in 2011, I think it was now, and there's a robust evidence base for acamprosate. There's been several thousand patients in over 20 trials. It's a moderate but significant benefit, and the key thing about acamprosate is that it is for the sustaining of abstinence. It is not for people to kind of go back to, to prevent increased drinking. It really does sustain abstinence, is his point. So by the time people are sampling a bit and going back, they may well be better on naltrexone, which is why naltrexone came out in the BAP guidelines as first line choice for people with bipolar disorder, just because you've got that kind of impulsivity and the likeliness of sampling. Whereas acamprosate is very much for the maintenance of abstinence, and therefore we use it early after detox. And ideally, if you're starting somebody on a detox, you may as well use it as part of the detox, because it is anti-glutamatergic as well, and therefore is likely to kind of reduce some of those alcohol withdrawal symptoms, which is the thing that kind of often gets people craving early post detox and makes them want to go back to alcohol. So certainly there's a good evidence base for both that and valproate, naltrexone. And naltrexone, the other thing to say about naltrexone is that you really just need to check that people are not using opiate containing compounds. And naltrexone does tend to work better in people who might have the odd lapse, who might, try some alcohol, because in some ways it kind of works by that learning mechanism in part, so that people have it, and if they find alcohol is less reinforcing when they drink it, they're less likely to take it again. So I would use it for those two sort of different patient groups.
I'm going to move on to a question about opiates, but before I do that, I'm just going to say, because we have got very little time and it will end, is please don't worry, because we are planning a webinar series and these questions are wonderful for us to be able to plan to see what you're worrying about, and we will honestly use them if we haven't answered them today, which we won't have managed most of them. Lesley, this is probably really in a hospital setting. Chan Nayen's asked, and I think is asking in the context of a liaison psychiatry setting, but could also apply to an acute psychiatric ward, is talking about the challenge of stabilizing methadone in the first week or so for people who've really been using a lot of heroin. And the problem being you want to titrate up safely and successfully, but people leave really or default from their medical treatment during that. And how do you tackle that very tricky problem if you're a liaison psychiatrist or in an acute ward?
Yeah, I mean, I think it is extremely difficult. As I said, it's easier if the service user is known to the community drug service and someone knows their history and is able to know, say, for instance, how high a dose of methadone they've required before. But I think it is initially, certainly for the first 24 hours, I think you have to go back to the first principles we talked about and start at a low dose. I mean, some protocols will say 10 to 20 mils as a start dose, so 20 milligrams of methadone, and then 10 mils 4 to 6 hourly. But again, most protocols will say up to 40 mils the first day. And then the second day, you could have 40 mils plus, again, the start doses of 10 mils, 4 to 6 hourly. But again, people are not really looking to get up to 60 mils, much beyond 60 mils on inpatient units. I think it's a lot also about the reassurance of the service user that you are going to be monitoring it constantly. And when they request methadone, even though they're not intoxicated and they're within the boundaries of the chart that they're allowed to get it on request if they're not intoxicated, as long as it's within the scope of the protocol, rather than actually waiting for full-blown withdrawal. Because I think it is just that fear of not being listened to. And I think if you've got a liaison, if you've got a community drug service who has a liaison worker, again, bringing them in to support the person and reassure is really useful as well. But a lot of it is reassurance and constant monitoring.
You can also use adjuvant treatments.
Yeah.
So, in a general hospital, if you look on them in the Maudsley guidelines, there's a table of adjuvant treatments that you can use to tackle specific symptoms of withdrawal. So it's about a dialogue and understanding that the person's in extremis and working with them. And I don't know, I mean, in the general hospital setting, my usual experience is I have a dialogue with the patient, we get some collateral, and then we say, look, it's going to be a difficult week, but this is where we're going to aim and this is how it's going to happen. And as Lesley was saying, that really reduces the level of worry. And the other thing that's really important is once people are on BD methadone, you have to really explain to the ward nurses that they need to give it on time. This is not something they can be late with. Because I don't think they recognise that as much as they should.
I think we're on a countdown now. So Julia, I don't know if you'd like to close quickly. On mute.
I'm on mute. Are we not allowed a quick question on methamphetamine? I saw that there was some in there, or do we need to go? Oh, it's 2 minutes to. We probably do need to go. That's shocking, isn't it? We will be booted out by the Royal College of Psychiatrists otherwise into outer space. So all I can say is thank you so much for coming. Thank you, Sarah, for helping to kind of keep us all in order. It was, as you could see, quite hard to do everything in the time allowed. But as I said, this is a taster session, colleagues. So please do come back for more. Because we're really keen to kind of roll out and have these discussions and try and improve the evidence base. The alcohol care team, the alcohol guideline is going to be coming out in July. So please do look at that and update your trust policies as part of that. And it just remains for me to thank Dr. Nicola Kalk, Dr. Sarah Welsh and Dr. Lesley Peters for doing fabulous talks and for joining us this afternoon, and Sarah for chairing us, and to the Royal College for facilitating it all. So thanks everybody very much indeed, and take care, and hopefully see you at one of these soon. Bye bye.